Respected chairpersons, colleagues, friends, good morning to all. At the outset, my sincere thanks to Dr. Srinivas Reddy for invitation of this STAR LiverTalkx conference and congratulating all the organizing members of the things. So, if you see the renal dysfunction in cirrhotic background, almost 40% of the individual, whatever day-to-day practice we are seeing, at one point will have the renal dysfunction. Same thing will increase in ICU setting, goes to the 60% of our decompensated chronic liver disease. This renal dysfunction significantly plays a major role in the mortality. That's why in the MELD score also, which the only one organ, the creatinine, has been incorporated in the assessing the short-term mortality. HRS-AKI is a unique phenotypes. We will go into a little bit details. Earlier days, type 1 HRS, type 2 HRS, and the definition was based on the serum creatinine more than 1.5. So nowadays, we know the serum creatinine is not a good marker because earlier Dr. Mithun also quoted that how the serum creatinine will be value less in a female gender and in sarcopenic individual and so many factors. So the baseline of the creatinine, we have to take if there is a rise in more than 0.3 milligram DL within 48 hours, then we can call it as a AKI, acute kidney injury. And at the same time, if you take within a week, last 1 week previous, the patient comes, in the 1 week time, it shows the renal parameter increase more than 50% above the base, then also AKI. Or in the last 6 hours, it is very useful in the ICU setting. Even though creatinine is not that much increased to 0.3 in the 48 hours, if the urine output has reduced less than 0.5 ml per kg body weight, we have to call it as AKI. The AKI, even though it's a broad terminology in the background of cirrhotics, HRS AKI, but we have to classify as a stages just based on the creatinine rise. If the stage 1 AKI means the creatinine value should be 1.5 times to the 2 times higher than the normal range. If the serum creatinine level is 2 to 3 means stage 2, more than 3 of the normal range, the upper limit, that is called stage 3. Because we are seeing in our practice, some patients will see with the serum creatinine of 1.6. Some of the patient, first time we will see the creatinine level, even though it was normal earlier time, within 40 hours, 3.5. So we have to start to write in the stage, HRS AKI, what is the stage? 1, 2, 3. So what is the usage? Because it's a bidirectional way it will work. Some of the individual AKI 1 stage, there is a chances to progress to 2, 3 in the due course. Some of the time, due to the preventive strategy or the treatment strategy, we can bring back to the stage 1 AKI or sometime normal. Whatever say, so if the data from the ILBS Kimeva, so close to 50% of the individual, the AKI will be in the either persistent or progressive nature. Persistent means we can say AKI up to only 7 days. Beyond 7 days, if the AKI persistence, we are not calling it as a HRS AKI, we are calling it as a AKD, acute kidney disease. So that's why we have to write it out in the case summary and follow up, either HRS AKI or if the creatinine level is persistently high, there is AKD, HRS AKD, that time the outcome of the patient will be poor. So this is the normal, the dynamic course. Within the 7 days, based on the definition, either the rise in creatinine more than 0.3 milligram per DL or urine output, or the last 7 days, what about the rise in 50%? But once it crosses more than 7 days, Suppose some patients treated outside hospital with AK, and if you come to us, that time also it shows the creatinine high. So it is called AKD if it crosses more than 7 days. That time we have to use the formula, the GFR only. The GFR is less than 60%, then we have to write AKD. This AKD, still it's a reversible, we have to revert back, we have to try to attempt, but most of the time, the earlier previous slide I showed, there is more chances to progress to the CKD. That means if it persists more than 3 months. That time either it may be non-olivuric or olivuric. Non-olivuric means we can manage medically. If it goes to the olivuric stage, that time they might require the renal replacement therapy. So what are the precipitating factor for this, the dramatis, the deterioration by the liver cirrhosis by the AKI? If you take the AKI in any diseases, which all is now here also come into the picture, either hypovolemia or the toxins or sepsis or a combination of this component. But we are dealing a patient with a decompensated chronic liver disease. If you look into that, we have to try to identify which precipitating factor particular to our hypovolemia means whether it's a blood loss related hematemesis, or it be due to the large volume paracentesis, or due to laxative induced diuretic. That's why we have to apply our knowledge. And with the toxin means either the nephrotoxic drug, either contrast, we are giving the either CAG, or we are doing CT abdomen, or sometimes due to diuretic induced. So what type of toxin, or sometimes antibiotics. So our sepsis, either is a SBP or non-SBP, even though the patient have a cellulitis or any other infection, that also cause, or combination of the things. These all will be we know the precipitating factors for the HRS in a liver cirrhosis. If you look into the pathophysiology, whatever I have showed in that, we have to apply the factors. If you see, some of them will be in the splanchnic vasodilatation, some of them will be in the renal pressure. And if you see the last one that is important, so earlier they thought HRS is the non-structural damage. Now we are accepting there will be a structural. So initially it will be the normal kidney, that means functionally good, structurally good. At one stage it is progressing to the structurally good but functionally not good. Another stage comes both structural damage and the functional damage. So then based on the duration, if it is a 7 days to 3 months, it is called acute kidney injury. If it progresses to beyond the 30 days, it goes to the chronic kidney disease. So this is the basic picture. We know the liver disease and where we have to focus on the patient's susceptibility. Old patient, they are more prone to get the HRS AKI. If the patient gender, so mostly few papers support the female gender. And the patient have the associated comorbidities. So one thing, we know the decompensated chronic liver disease, and another thing, so we have to see the patient's demographic data. This way we have to try to avoid that precipitating factor that will prevent the AKI. So preventive strategy is not a treatment strategy. So we know that our decompensated disease are vulnerable. We know the AKI is rising the mortality, and the stage also we know how it's progressing and how the mortality rate increasing. So what are the preventive strategy? So whenever the contrast media, so adequate hydration we have to do and withhold the diuretic. And NAC, based on the study, it is not helpful, but in day-to-day practice, we are giving NSTL-16 prior to the contrast and all the things. And volume depletion, how we have to avoid. See, the practice, each one of the things we have to, preventive strategy, if you take it, we can somehow control the AKI incidence in the background of chronic liver disease. This we all know, but one thing, the variceal bleed, we have to start the antibiotics. Same way, if there is any sepsis, either SBP, we have to give albumin with the antibiotics. And any bacterial infection, again, albumin with antibiotics. The purpose of the albumin here, to keep the MAP at adequate range, more than 85. So this type of preventive strategy we have to apply in our decompensated chronic liver disease, particularly if they have so much of the comorbidity and other things. And the nephrotoxic medicines, so many, even whatever antibiotic we are using, we have to be careful, particularly all the vancomycin and the augmentin, that kind of amoxicillin groups. Major abdominal surgery, sometimes they are going to take care, again the MAP and so many factors will involve if the patient have the umbilical hernia repair or so. There, after the surgery, not only the decompensation in the form of the liver disease, they will end up with the AKI and there will be a deteriorations. So how to manage all the things? AKI stage 1. So stage 1 means I told that the rise in creatinine should be 1.5 to 2 times. If other all, aka 2 stage, 3 stage, directly we have to give albumin, and if there is no response, we have to use the vasoconstrictor therapy. If still there is no response, we have to go for renal replacement therapy. But in stage 1 alone, we can prevent we have to correct all the factors, and based on we have to wait and watch policy, we can use it. And the management of HRS, quickly we all know, HRS AKI, here it is the HRS AKI, and it is not applicable for the non-HRS AKI. Non-HRS AKI component are the, I already mentioned, AKD and CKD. So in AKD and CKD, this is not applicable. In HRS AKI1, within 7 days, so we are noticing rise in creatinine or urine dropout, everything. That time we can start with the Terli with albumin, either the infusion or the, so now most of the centers starting the continuous infusion therapy. In case Terli wise there is no response, there is no improvement in the renal function, then we can increase the terlipressin dosage. Similarly, we can increase the albumin dosage even up to the 40 gram of the albumin per day. Still there is no improvement, we have to go ahead for the renal replacement therapy. The tips and other options, liver transplant, usually with the AK, if you are going to take, and at that time it is conduct. Even though the recommendation, the paper mentioned ESL practical guideline, but we all know tips is not is a contraindication in the presence of the renal dysfunction, and particularly the liver transplant, emergency liver transplant is not acceptable because that time that's affecting the overall post-operative period. So when we have to discontinue the therapy also we have to know, and alternative to the Terli, some of the patient will not tolerate the terlipressin. That time we can use the midodrine with octreotide. The problem with the midodrine, so some of the times along with the beta blocker, that will cause the bradyarrhythmia. So the bradyarrhythmia only, suppose sometime we will go for the atrial fibrillation and all the things, VAF, ventricular flutter and everything. So that alone, while giving the midodrine, we have to be careful about the things. And this already I mentioned. So this paper I just showed to that, if the patient going for the RRT due to the AKI therapy, if you see this is the study on 722 patient follow-up, less than 25% only they are recovering. So most of them going for the persistent, that means already CKD. So once the CKD develops, we have to think about the combined liver and the kidney transplants. These are at the time when to start the RRT. There is no consensus, either early or late, because both the side, there is no much improvement in the mortality benefit. But we should do the RRT, but at the same time, we have to prepare, we have to counsel the family members. There are more chance, 70% of the individual, there is more chances to go for the CKD. And what about if you are going to do the patient, the immediately transplant? That's why I mentioned in non-responders. So AKA groups or AKD groups, if you are going with liver transplant, emergency liver transplant, if they are already responded with the therapy, means that time the chance after liver transplant, they will not get the kidney function revert back. If there is not much partial responder or non-responder groups, they'll go for the CKD. That's why some of the patient, even after the liver transplant, we are seeing the elevated renal parameter, and due to the immunosuppressive therapy, whatever the TAC and CNA sparing drug we are using, the renal disease will progress. To summarize this, so cirrhosis, impaired renal dysfunctions, poor prognosis, high mortality. We know the spectrums. We have to know what is the AK 1, 2, 3 based on the assessment. We have to see either with the therapy, whether the reversibility is there or not. Preventive strategy is always better, and also close monitoring. So before to conclude, see, this is the pictures, because the biomarkers, it's not much helpful in the patients with the HRS-AK. Biomarkers are useful for the HRS, that particularly AKD, CKD. But routine analysis, suppose urine routine we have to send. If you are seeing the hyaline cost is nothing but the mucoprotein, uromodulin, the protein. It is commonly we see in the HRS, AKI, and all the perirenal. If you are going to see the WBC, that time it is acute interstitial nephritis. If you are going to see the RBC cost, it associated with the glomerular nephritis. If you are going to see these other, the granular cost also the mucoprotein with the debris. This we will see mostly in the ATI groups. So urine routine is important. That's why we can somehow apply the basic biochemistry knowledge in the further assessment. Thank you so much for everyone and kindness.
It was a very nice presentation, sir. So a small question, sir, like SGLT2 receptor role in HRS prevention. Any emergent data on that SGLT?
It's a SGL2. At present, I have no much knowledge about that one, and whatever the at present recommendation also, it has not been included so far in our HRS.
Any questions from the audience?
Excuse me, sir. Sir, I have a question. In a patient with HRS-AKI who shows improvement with terlipressin and albumin volume expansion, but even after the improvement, the creatinine is still high. For the evaluation of transplant workup, is a kidney biopsy indicated to rule out a CKD component?
Kidney biopsy is not indicated now, because already most of decompensated chronic liver disease will have all the high coagulopathy, ascites, so many things. So what we should understand, the improvement is complete reversibility. So what you are saying, there is an improvement, but still they are in the renal parameters high range. Whenever the renal parameters is above the normal range in more than 7 days, we have to call it as AKD. So that case is at the time of taking a liver transplant, they have the AKD. That AKD groups, there are the chances to revert back, but they are still, that's why I said, partial responders or the non-responder, there is more chances to progress to the CKD even after liver transplantation.
Thank you, sir.
Thank you.